Good evening. I'm coming to you live from Chateau Faulkner in Mayflower, Arkansas. Sorry, that was the tail of my golden retriever, Sadie. Say hi, Sadie. She's got my shoe. She won't chew it up. She just thinks that it's convenient that I might need it, and she's got it handy. Anyways, she makes very strange noises, and since I'm recording in a different part of the house where there's no aquarium noise, I don't want you to miss out on the strange noises in my house. So if you hear things that sound like Sasquatch, it's actually my golden retriever. This lecture will be for the pulmonary chapter. And again, I'm sorry that everything's been so late this week. I had a lot of trouble getting the videos uploaded, but don't worry. Just because things are spelled out the way they are on the syllabus doesn't mean that you have to study heart and pulmonariology this week. And I think I just said pulmonariology. That's a new specialty. There's also pulmonology. Anyways, you've got plenty of time. Don't worry. The next test or quiz is going to be, straight from the book. It'll be very similar to the first one. Content's a little more intense, but don't worry. You're all going to do well. On page 158, there's a table down at the very bottom that says drugs used in the treatment of pulmonary diseases and disorders. Not really any test questions are going to come from that, but it has every medicine that I actually prescribe on it. And most medicines I prescribe in the acute setting are medications that I intend to be continued in the primary care setting. A lot of people come to me with exacerbations of COPD or asthma, and they've been managed by their primary care provider for some time, but they may have turned a corner. Now, it's also very, very much influenced by seasons, and the fall and the spring are the worst when things change. Summertime, wintertime, things will actually plateau out in the middle of those seasons because they're longer stretches of the same type of climate conditions. Spring and fall are full of all kinds of changes, and lots of irritants are introduced into the air. So these people have lots of exacerbations during those times. Anyways, something that is beneficial for both COPD, which remember the thing about COPD is it's chronic bronchitis and emphysema. The emphysema is actually the worst part. That's the air trapping in the lungs. It's like filling up a balloon slowly, and at some point, you just can't put any more air in it. Well, that balloon's your lung. Sucks. Anyways, asthma, reactive airway disease. It's an allergic-mediated response, so we immediately think of the emergency rescue inhaler, albuterol, standard. It's a bronchodilator, a beta-2 agonist. So, on on page 159, it talks about the bronchodilators, and here's what I want you to know for these pages are full of all kinds of information about the drugs, and I talked about this in the cardio lectures as well. There's the mechanism of action, pharmacokinetics, adverse reactions, thus and such. Though that's good information to know, obviously. Clearly, you need to know what could possibly go wrong with what you're prescribing and how it works. But many of these medications are mainstays, and the people who require these, they have to have them. So what you'll need to pay attention to in the future is what other medications are they taking that these might interfere with. So for now, we're going to talk strictly about what they are, what they're used for, kind of like I said, foundation type stuff. You'll have the next year or so to figure out all about how you will prescribe these, and that will happen best in your clinical setting. That's where you're going to ask your preceptors, okay, here's what I think we need to do. Now, how shall we prescribe this? Or you might have your reference and you say, I think we'll give this for how long and blah, 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 and they'll be very impressed. Okay, so there are short-acting beta-2 adrenergics and long-actings. The main thing is when you have a long-acting beta-adrenergic. Sorry, y'all. This is crazy. It's Friday night. I've worked about 5 weeks straight, and I just got home from setting a trot line. Not in this shirt, trust me. Anyways, long acting are going to often be combined with short acting. So, short acting, rescue inhaler. Someone who's having acute respiratory distress, either from asthma exacerbation or from COPD exacerbation, they're going to use their inhaler, take a puff or two of it, and that will open up the lungs very quickly. Now, the action, of course, is short-lived as well. Those people may have a recurrent flare-up because they're short-acting. So, with asthma, usually you will terminate the reactive airway with a short-acting beta blocker. Now, or beta, sorry, not beta blocker, beta adrenergic. For the case of COPD, we think of updrafts. So, combination medicines, a Duoneb, which is the brand name for a combination updraft, which has albuterol, the short-acting beta-adrenergic, and it has ipratropium, which is the long-acting. And people benefit from those. Now, I've had patients, and these are the patients that you're going to be sending to the hospital who have had sort of a status asthmaticus. Not only do steroids help, but these combination updrafts help as well, because it helps abate their symptoms. The long-acting bronchodilators keep the airways open for longer periods of time, as opposed to the short-acting, where it's the hallmark of status asthmaticus is you just can't make it stop. So that's the main thing I want you to know about bronchodilators. There's a short-acting rescue inhaler. There's a long-acting, which is typically combined. For quiz purposes, I would probably imagine something like it's, October, November, and all the COPD patients are starting to come to the clinic with a cough, with worsening shortness of breath. They've probably got a bronchitis flare-up. Some of them are probably still smokers. What treatment would you give in the office? And an updraft treatment is perfectly fine to give in your office, and it's also perfectly to prescribe from the primary point of view. People can get nebulizers through their insurance companies and do these updrafts at home. Very beneficial. Okay, all of that is really more in detail on page 161. Now, on page 162, on the left column, down in the middle where it says xanthine derivatives, theophylline or theophylline, tomato, is more of a drug that you're not really going to use. I've never used one, and not that my experience dictates what your education should be, but they're still not used very often. They have a lot of side effects, the main one being that they induce arrhythmias, especially in the elderly. Really avoided these days. That's actually what I want you to know about the xanthine derivatives, like theophylline. They cause arrhythmias. So, for example, we've talked about cardiology recently. You have a patient who has atrial fibrillation. It's well controlled. They also have COPD. Heart and lung diseases go together. You're going to see it. And you find that in the past they've been prescribed theophylline or theophylline, and they come to your